As you know, since 2020, we've had approval of PARP inhibition for the treatment of prostate cancer for patients that have HRR mutations. These are most commonly BRCA1 and BRCA2 mutations, but a number of other less common genetic alterations associated with DNA, homologous DNA repair. And there are therapies that target the PARP protein in this context that can create a second hit, if you will, on the DNA repair mechanism. And in these patients with these genetic alterations, they're susceptible to this approach. And olaparib, Lynparza, was the first drug approved in this setting, and now we have additional therapies approved in this setting in combination with androgen receptor targeted therapies, pathway inhibitors, abiraterone or enzalutamide, in this setting, and there's several of these drugs. So it's likely to become more important now to consider this approach when we're considering our AR pathway inhibitors, which is early in the metastatic castrate-resistant disease setting. And so recognizing this change in the landscape and the need to understand when these HRR positive patients are becoming identified, it's important to understand where we are as a field. So we looked at Concert AI. Concert AI is a huge database of medical records collected through a number of mechanisms that really give us insight into practice patterns in a number of cancers, including prostate cancer. And we're able to partner with Concert AI to evaluate the timing of genetic testing, and particularly those patients that ended up being found positive for HR alteration. So, to answer your question, what was most fascinating and maybe frustrating for us was that for the patients that we identified, several hundred with HR alterations, their average time from castration resistance to diagnosis was around 18 to 20 months. Now, if you think about the real world median survival of patients with prostate cancer, it's right around 2 years. So half of our patients have probably died before they even got a chance to get testing. And then those that did have this alteration, and they may even have more aggressive disease, even more likely to die early, were found at such a late stage that probably very few of them could actually benefit from a PARP inhibitor at the time of olaparib. So we're late in the game. We're too late in the game. We're waiting until patients have exhausted their standard of care options, hormonal therapies, chemotherapies, to say, well, what else is there? Let's check for an HRR mutation, when that should be our first thought. Somebody becoming castration resistant or even at risk for becoming castrate resistant, let's go ahead and test them. And I think if we can change that mentality, we can open up the opportunities for patients, more patients to get treated with PARP inhibitors, and more patients to have more time to benefit from PARP inhibitors in this setting. It's a great question, and I think ultimately our challenges are in recognizing, these changes in the disease state. So castration resistant is a fundamental change in biology, and it's even becoming more important as we use our AR pathway inhibitors earlier in the disease, and these PARP inhibitors being tested earlier in the disease. Even castration-resistant disease state may be late in the game. But for right now, that is the disease state where these drugs are indicated. And I think it's going to have to be a recognition of the data that there's a real benefit for this subgroup of patients to get that combination in the setting of a PARP inhibitor. There's a nice presentation by Maha Hussain that really looked at the sequence of treating either with an AR pathway inhibitor or PARP inhibitor or the combination in these patients. And the patients that got the combination, rather than sequential approaches of either or, did much better. So that data really it really strengthens this concept of testing early. And I think that's the kind of data that physicians need to know. We're data-driven, physicians. I mean, oncologists probably more so than any other specialty like to have data to drive this. Even relatively small studies like that can really help to solidify why it's important to test then. And then making the testing easier for physicians to order, whether it be off of tumor tissue, whether it be off of blood, circulating tumor DNA, or genetic testing for germline alterations. All three of those really need to be built into our practices so that they can be systematically done without a lot of individual effort. These should be push button tests for us, and if they are, we can employ them early and use them to help inform this decision process. So that's my hope, and obviously that's something each practice, each health system's got to figure out. But there's a real benefit to doing this, and these alterations, they're frequent enough, 10 to 20%, depending on your practice and where you live and whatnot. That if you systematically treat, you will find them. Well, look, I think it's one more challenge, right? Already, the burden of managing patients with advanced prostate cancer is substantial. I mean, if you think about the things we need to cover for a patient with advanced prostate cancer, whether it be, hormone sensitive or castrate resistant, we're talking about a number of different treatment options from hormonal therapy and chemotherapy and combinations, a number of different hormonal therapy approaches, with either single agent or combinations, more and more often now combinations, getting those drugs approved and covered because they can have significant copays, counseling patients regarding the side effects and survivorship issues. These patients are living longer than ever, so helping patients understand the real critical value to diet, exercise, sleep, and routine in their lives. Helping manage patients who have side effects, pain, weight loss, other issues, urinary issues, and managing that. And then to be able to then add to this the conversation around cancer genetics and why we test and what we're looking for and what this biology means and how it could impact your future treatment is something that is not an immediate concern. And so it's something that can get tabled and lost. And it's something that I think we need support for. Just like if we're gonna, add a new hormonal pill, we need support to understand, and to have the pharmacy support and things to get those drugs, and the coverage, available for patients. It's going to be the same on the genetic side. Do we have genetic counselors? If something's positive, now what? And helping them figure out, well, we got to test germline and what implications this could have for your family and whatnot. So there's a lot that needs to go into this. It's hard to do it in isolation. Companies are really doing a good job of helping as much as they can, but I think institutionally, you're absolutely right. These are the kind of things we need to have. Thankfully, it's not limited to prostate cancer. Many of these issues come up in breast, ovarian cancer, pancreatic cancer, and others. There should be, a high enough demand now that most practices should have, at least some pathway for managing the positive patients. And I think, adding your prostate cancer patients to that pathway is really the critical piece here.